myocardial salvage and preservation of the LV systolic function. So right perfusion strategy should be done timely. It should be effective, complete, safe, and easily accessible. So you have to be practical in approaching STEMI patient. So whenever there is a scope for thrombolysis, if the primary PCI is not feasible, not feasible, cannot reach a PCI-enabled hospital on time, the cath lab is busy, you must focus on thrombolysis, and thrombolyze the patient as early as possible. Next slide. So selection of reperfusion strategy in STEMI. PCI is the gold standard. It is preferred but less accessible. Thrombolysis is easily available, economical, and evaluated in clinical studies also. So lysis followed by PCI, that is your pharmacoinvasive therapy, is an attractive option and bridges the gap between the thrombolysis and PCI. Next slide. So problem encountered, as I discussed in Indian scenario, that is lack of awareness about the services that are available, the treatment that are available, whether PCI is available, whether thrombolytics are available or not. Mistaking the MI with acid reflux disorder. Many a time patient presents late due to thinking of their side that is maybe a gastritis. Traffic jam, as sir has already mentioned, that in a densely congested populated areas, coming a patient from a distance of 60, 70 odd kilometers, it may take 3-4 hours or more. So losing vital time during the transit itself, lack of proper trained staff in the ambulance for first aid. Yes, it is very serious issue because many times patients do not get the loading dose. So we cannot even think of pre-hospital thrombolysis because of lack of educated staff in the properly trained staff in ambulance. Lack of health insurance, a major issue. Finance is a major issue. Trying to get too many options at the critical juncture, patient calls up his relatives, they call up other people, 2 more doctors get involved. So a lot of time usually lost in that discussion itself. Real doctor's view versus Google doctor's view. Yes, we do come across this scenario. A lot of opinion do come from the patient and their relatives. What best can be done from their side. And financial issue is the most important part, though the state government at many levels try to address it with various financial help or the cards, but still it is not enough. So in India, this is though we are focusing more on invasive procedures, but that is not yet practical. So we must focus on the thing which can be employed fast and which have a better outcome, at least by saving time and giving some space to do the invasive procedures later on. So considering these factors and practical scenarios, thrombolysis do have a strong role to play. And followed by thrombolysis, the role of invasive procedures. So pharmacoinvasive therapy definitely has a significant role to play in Indian scenario. Next slide. So trials comparing pharmacoinvasive versus PCI. So there are data available like STEP MI, STREAM, NorthSTEMI, Transfer AMI, West, and Capital AMI. So these are various trials where the STEMI patients presented within 3 hours to 12 hours of onset, variable onset. They were compared with invasive procedures. So tenecteplase was the lytic agent which was used. Pharmacoinvasive strategy was taken into consideration. So some of the trials they have compared with pharmacoinvasive versus primary PCI, and it was found that they are not inferior. So primary pharmacoinvasive is non-inferior to primary PCI in acute MI setting when the patient presents within 12 hours of onset of the chest pain. Next slide. So this is an Indian data. So a prospective study of a multi-center study where the tenecteplase facilitated PCI versus primary PCI, the STEP MI. So to compare the efficacy of pharmacoinvasive strategy versus primary PCI in patients with STEMI, around 200 patients were taken from 5 primary PCI capable centers in South India. So there were 45 patients who went for a pharmacoinvasive therapy with tenecteplase, and primary PCI was done in 155 patients. Primary endpoint was composite of death, cardiogenic shock, reinfarction, repeat revascularization of the carotid artery, and CHF at 30 days. Next slide. So if you see the 2 groups, Group A and Group B, next slide. Yeah. So if you see here, the death, reinfarction, repeat revascularization of the culprit artery, cardiogenic shock, and CHF are comparable in both the groups at 30 days, at 3 months, at 6 months, at 1 year. So values are almost similar to the both groups. Efficacy endpoint wise, death and reinfarction wise, all these parameter wise, these percentage-wise, they are almost similar with p-value nothing significant between these two to differentiate. So as per this STEP AMI study, pharmacoinvasive strategy can implemented in patients in patients not selected for primary PCI in India, and thus hints at possibility of similar outcomes. Next slide. So this same group of patients they were further followed up for 2 years. So those patients enrolled for STEP AMI, they are followed up for another 2 years. Next slide. So what they found, the survival advantage, survival benefit. So the primary endpoint was a composite of death, cardiogenic shock, reinfarction, repeat revascularization, and congestive heart failure at 2 years. So the survival distribution between the two groups, that is tenecteplase plus primary plus in PCI versus primary PCI, the distribution is not significant. So they concluded that the pharmacoinvasive strategy, which results in outcomes that were comparable to primary PCI at 2 years, suggesting it might be a viable option in India. A larger studies are required to confirm findings, but at least gives an insight that this is the scenario that where we can get a almost comparable result to that of a primary PCI with pharmacoinvasive approach. Next slide. So another observational study of around 138 patients where the patient with STEMI within 24 hour symptoms, they underwent primary PCI or pharmacoinvasive PCI. They have utilized streptokinase here. So it's a single center over a 9-month period, and primary endpoint was death and re-MI within 30 days and cardiogenic shock. So next slide. So numbers are less, but still they could say something that in this trial, the primary PCI and pharmacoinvasive. So primary PCI was done in 95 and pharmacoinvasive in 43 patients. So overall, the primary endpoint was not different between these two groups. Rather, if you see here that the death rate, overall mortality, cardiogenic shock, and re-MI were less, but okay, statistically, they are not very significant. In a 1 month of follow-up, the incidence rate of primary endpoint was 5 events plus per 43 patients. That was almost 11.6% in pharmacoinvasive arm and 18 events in 95 patients, which is almost 19% in the primary PCI arm. Also the secondary endpoints are almost comparable. So as per these small data that we have of around 138 patients, the pharmacoinvasive strategy was found to be as good as primary PCI in STEMI patients. Next slide. So another, it's a meta-analysis was done comparing the primary PCI versus a pharmacoinvasive PCI of around 13,000 patients to observe how pharmacoinvasive therapy stands against the primary PCI in terms of safety and efficacy. So next slide. So if you see here that all-cause mortality, all-cause short-term mortality, likelihood of achieving a TIMI-3 flow, the odds ratio is similar in both the groups. So it doesn't favor either groups. Total stroke, however, hemorrhagic stroke, ischemic stroke is slightly higher in the, slightly higher, favors the primary PCI, that is, it is higher in pharmacoinvasive probably. But beyond this, the other parameters are almost similar. So all-cause short-term mortality and likelihood of achieving a TIMI-3 flow is similar in these both the groups. So overall, there is no significant difference in short-term mortality. However, there is a small group of patients who presented late. So pharmacoinvasive therapy significantly decreased the short-term mortality in those studies with a symptom to onset device time more than 200 minutes. So where the PCA was done a bit late, so symptom onset to the device time is 200 minutes or late. In such studies, it was found that pharmacoinvasive therapy, it reduces the short-term mortality compared to primary PCI. So in their subgroup of patients. Otherwise, if it done early, they are almost similar, no difference between these two. However, maybe a slightly higher chance of stroke, particularly some small risk of hemorrhagic stroke. Next slide. So in the summary of this previous slide is that timely intervention to revascularize the occluded coronary artery is the mainstay of treatment for patients with STEMI and should be achieved ideally as soon as possible. Delays in primary PCI can result in increased mortality and morbidity. Pharmacoinvasive therapy using a third generation lytic can be a critical reperfusion strategy in many patients who present to a PCI center where delays or in primary PCI is anticipated. So it can be a life-saving option for the patient presenting to a non-PCI center. That is very important. And for those who are living in rural and semi-urban region. So that is an extremely practical point, which is mentioned in the lower line, that it is a life-saving option for patients presenting to a non-PCI hospital or rural areas where access to PCI center is not possible. So thrombolysis should be given that preference in such scenarios. Next slide. So we need a thrombolytic agent, which is having enough data to support this efficacy. So ease of administration, onset of drug action, safety, efficacy, cost versus benefit, real world evidence. So these are the key attributes to the selecting a thrombolytic agent. So next slide. Next. So there are data in favor of our tenecteplase. So a pharmacological reperfusion therapy with indigenous tenecteplase in 15,000 patients with STEMI in Indian registry. So over 15,000 patients across 722 centers from India. Next slide. So what they have found that clinically successful thrombolysis from the time of presentation. So overall success of thrombolysis was 95.43%, which is I think very significant. And those who presented less than 3 hours, the success of thrombolysis was 96.54%. Those who presented between 3 to 6 hours, it is 96.07%, and those who presented beyond 6 hours, it was 85.38%. So this study confirms the safety and efficacy of indigenous tenecteplase in Indian patient STEMI. So this is next slide. So similarly, another 7,000 odd patients, they were taken from January 2011 to February 2016. Again, there was data was taken regarding pharmacological reperfusion with tenecteplase. Next slide. So overall, of clinically significant this thrombolysis. So it was with tenecteplase was found to be 93.34%. There was 93% patient who had a chest pain resolution. Over more than 91%, they have a 50% resolution of ST segment elevation at 90 minutes. So overall, 53% they died, which was almost 7% before discharge. And the incidence of bleeding, excluding stroke, was 1.7%, and any stroke without ICH was 18.18, and ICH was 0.38%. So it is about a large group of patients being seen and represented, and being like these data are based on those number of patients who received tenecteplase. Next slide. So the finding of this study further reinforced the safety and efficacy of indigenous tenecteplase in Indian patients presenting in STEMI, including high-risk subgroups. Next slide. So we have this STEMI management guideline consensus on STEMI during the era of COVID. So it was just that a patient with during COVID-19 era, STEMI, who has presented the STEMI. So if he enters a STEMI network, enters the STEMI network via ambulance, so he will transfer the hospital with 24/7 cath lab. So timely PCI, primary PCI is possible. If yes, go for primary PCI. If no, go for fibrinolysis. And following fibrinolysis, we can take him up for invasive therapy for within next 24 hours. And next option is here, if the patient self-present to a hospital or hospitalized with COVID-19, he present to a hospital with 24/7 cath lab, go for a primary PCI. If not possible, go for fibrinolysis. If goes to a hospital without 24/7 cath lab, then whether he can be transferred safe within time to another hospital where cath lab is available. If yes, go for a primary PCI. If not possible, go for fibrinolysis. So the idea is that if the cath lab is open, if all the parameters are okay, you can go straight away for a primary PCI if he reaches a PCI enabled hospital. If you cannot reach a PCI enabled hospital, then if the transfer time is more than 2 hours, you should get thrombolysis then and there itself. If it is possible to transfer him within that period of time, then you go for a primary PCI. So in nutshell, it says that your thrombolysis is an option which should be always available without delaying much time. Should thrombolyze the patient, and then we can also send the patient for a invasive approach if the patient is not admitted to a PCI enabled hospital. Next slide. So far I have discussed the role of pharmacoinvasive therapy in Indian scenario, and we can see its utility in Indian scenario, and the studies that we have to support its utility. It has found that it is at least non-inferior to a primary PCI. So I'd like to conclude here. Thank you for your patient hearing.
Thank you, Chinmay, for your nice deliberation, and I find that Arindam has also joined by this time. So, very nice elaboration of the pharmaco-invasive strategy and also primary PCI, and a nice, comparison. Just to refurbish some of the National Intervention Council data, because we toiled hard last year. Also, we presented the data during our Cardiological Society conference, and it was similar to the 2017 data, NIC data, which was in Hotel Ashok, New Delhi. And there it was shown that only 40% of the patients following acute MI got some sort of thrombolysis. The details were not available, but majority received streptokinase, which is the cheaper one, but substantial portion of the patients also received tenecteplase because it's very easy to deliver, single shot. It can be given then and there. The intracranial hemorrhage is lesser than the other one, so it's a better one. And the primary PCI situation is very dismal. You will be amazed to know that only 1.6% of the patient, around total 30 lakh patients at STEMI, I believe the numbers will be much more, but that was the data available in 2017. And this is the data last year also around this. It was little high, but the data is similar, that not even 50% of the patient got reperfusion of some sort, means not necessarily primary PCI or pharmacoinvasive approach. The 2017 NIC data shows that there were 1.6% of the patients received, this pharmacoinvasive approach or primary PCI, but the details were not available. How many were primary and how many were failed PCI, how many were pharmacoinvasive PCI. So this is the scenario in our country. Whereas in very small countries in the Europe like Belgium, Holland, France, and not to tell of the Scandinavian countries, and now also in UK for the last 3-4 years, because previously in UK even 7-8 years back, not too many primary PCIs were done. But nowadays they do a lot of primary PCI, almost more than 90% of the patient. So the situation is much different in other countries. Of course, in US it is a mixed data. Like in North Carolina, their task force chairman was telling me in our STEMI conference, he presented the data and he showed that 25% of the patients in North Carolina were not reperfused either by thrombolysis or by primary PCI or pharmacoinvasive PCI. So the situation is very uneven, even in US, not to tell of our country, not even 50% of the patients are reperfused, though the CREATE registry data showed a little more, 57%. But our data was very meticulously taken, and we are taking the data even in the COVID scenario. And this year, 24th, 25th of July this year, we have our national meeting, and I would invite all of you to join with us, please, from 3 o'clock to 9 o'clock in the evening. And there will be presenting the data in the COVID scenario. I believe it will be very interesting data, and will show how much is the decline in the incidence of the interventions, how many of them got thrombolysis, and what is the situation in the COVID era. So, Chinmay, you have presented your data very nicely, but it's really dismal that in our country, the situation of reperfusion still very poor. I think this indigenously made tenecteplase is a very good value addition to the armamentarium. And when we can't go to the hospital, in any center we can go for early institution of this third generation thrombolysis, though there is not much of a difference in mortality between streptokinase and tenecteplase or retiplase, but still we favor this third generation thrombolytic agents because of their ease of giving the parenteral dose. Just in one shot you can give tenecteplase, and especially now the variety manufactured abroad is not available, so we have the option of giving this tenecteplase from indigenous sources, and we have seen the data that is working very well in our population, and the lysis rate is much higher than the international figures. Just to remind that with tenecteplase, the reperfusion rate at 90% following in the infarct-related arteries 62 to 63%, same rate 61 to 62% with retiplase 2 doses given at an interval of 30 minutes with enoxaparin or other antithrombins given before and 20 minutes after the thrombolysis. And but here we saw that the different data you presented, the thrombolyte, the patency of the IRA means infarct related artery was much higher, 95 to 96%. So Dr. Chinmay, have you got any comments about that?
Yeah, I was also surprised to see so many, more than 95% patient have recanalized arteries with successful thrombolysis. But that is, I don't know, that is not my experience with thrombolytics probably. So in very practical sense, probably 9 out of 10 or 8.5 out of 10 will be having a patent artery or a successful thrombolysis. Rest will have a failed thrombolysis. We need a rescue PCI sort of things. But this data has specifically shown there's 95 to 96 out of 100 getting a successful thrombolysis. I do not know. Means how good this is,
Yeah,
I
it
do not
seems
know.
to be very high. Yeah.
Exactly,
Dr.
sir.
Pandey, any comments? Dr.
I also
Pandey, any
agree.
comments?
Also agree with Dr. Chinmay and yourself as well. I do get patients who are thrombolized outside, but patency rate will be to the tune of 60 to 70%. I'll even
Yeah,
further
that's right.
more.
Yeah, yeah.
Yeah. So
I am absolutely of the same opinion that the patency rate is 65 to 70% in our country. Yeah, it's little better than streptokinase. But very surprisingly, in this connection, we want to mention that the patency rate with tenecteplase or retiplase is double that of streptokinase. That is, with streptokinase, it is 32% at 90 minutes, whereas it is 62 to 63% according to the universal data international data bank, that it is 62 to 63% with tenecteplase or retiplase. Though the patency rate of the IRA is twice that of streptokinase, but the improvement in mortality has not been translated by these new, thrombolytic agents. We do not know why it is like this. That we'll have to find. But there is no doubt that the incidence of intracranial hemorrhage, the incidence of major hemorrhages is much more with streptokinase, and the patency rate is much, much inferior, and it is 200% better with these newer thrombolytics like tenecteplase or retiplase. So I think Dr. Professor Kajol Ganguly has joined, and I have seen Professor Sharma. So I would seek your valuable opinion regarding this discrepancy between the actual patency rate which we see in our practice and what we have seen in the studies. What is your opinion? Because you are very experienced professors, and also comments during the pharmacoinvasive PSCI in our setting, and how
Yes,
we can improve the reperfusion rate as a whole in our country. What should we do in a very short? How can we improve the reperfusion following STEMI, or rather our STEMI services across the country? I was the convener of STEMI Council of India for 1 or 2 years, and we had meeting with the chief secretaries, ministers of 20 different states of India during our STEMI conference. but we see that there is not a lot of improvement in the situation. So what is your advice, by being a senior professor and in this field for more than 30 years? I would ask Professor Ganguly and Professor
Uh,
P.C. Sharma to have your
Thank you,
short
Dr.
opinion. Thank you.
Thank you, Dr. Kahali. I'm audible? Am I audible?
Yeah, Kajol, you are audible. Yeah,
Thank
Kajol,
you,
you are
Dr.
audible.
Kahali.
Yes, yes,
Thank
sir.
you, Chinmay,
Yeah.
for a beautiful deliberation. Our slogan
sir.
always has been in our country, lies now, stent later. See, that encompasses everything. So most of the patients should be lysed, and we have got a huge success, as you can see in the STEP AMI trial by Alexander Mulasari and others. I presented the data in Japan Heart Society Association in 1915, and there Dr. Alexander has proposed the spike and wheel mode of presentation. Mode of presentation in the distal hospitals should be A, B, C, D category. D category and C category, the patient should be thrombolized and then should be sent to this PCI capable centers. So that is mostly the pharmacoinvasive therapy, and that is been advocated by other states also. Some of the states like Karnataka and then Hyderabad, that is the Telangana and others, have taken that cue, and the government is propagating this phenomenon. So this is the only way how you can take up this thrombolytic to the general population in the distal periphery, so that we get patients who are thrombolized come to us and then do the that is the pharmacoinvasive therapy, and that needs total initiative from the government, CSI, and other NGOs to make it very successful. This spike and this wheel appearances of therapy in AMI. Now, regarding this pharmacointensive therapy in COVID area, obviously we shall choose this pharmacoinvasive therapy. We lyse the patient and take time to settle down, and then take up the patients. Except one or two hospitals in Kolkata, they have got dedicated cath lab for this for COVID patients. There they can take up the patients who are at high risk of after STEMI, like hemodynamic imbalances or in arrhythmias for primary PCI. Otherwise, they are stable patients can be given these pharmacoinvasive therapy. Results are equivocal and almost the same as shown by the STEAM trial and this transfer AMI trial and last step AMI trial.
So thank you,
Thank you.
Kajal, for your excellent remarks, Kajal. So I would invite my good friend, Dr. P.C. Sharma, to have your short, comments, how we can increase the reperfusion rate in our country. You are a very experienced cardiologist, professor, very dynamic doctor. So how we can, sir, increase the number of reperfusions following AMI in our country? What is your advice to the population?
The scenario in our country has been already explained, that most of our people, in my place particularly, we do not get patients within 6 hours, not even in 12 hours. Many patients come after 2-3 days. This is because of unawareness, or maybe that people are not aware. Some physicians are misleading, like gas problem, as Chinmay has already told. So that is the main hurdle in MI treatment in our country. So, and of them who reach hospital, so in our place, we do not have say PCA facility anyway, but we can give thrombolytic and we can transfer the patients, and that is the best option in our country. The pharmaco-invasive is the best option in our country. Even if you are sitting in a major hospital, the city, the traffic jam and all, and the finance problem, our people are not insured. The finance problem is also a big issue in our country. So pharmaco-invasive is the best option. And regarding the thrombolytic therapy, as Chinmay has shown in his data, that more than 90%, maybe 96% patients are receiving streptokinase, because people are more comfortable. Streptokinase has long-term experience. They are scared of using the new thrombolytic drugs. Even we are not using that frequently because of the finance problem. Patients are People are ready. People are ready for a cesarean section, financial, but not for MI. At midnight, someone developed MI. They are not ready with money. So anyway, we'll have to follow that guidelines. Primary PCI is the gold standard, but for our population, that pharmacoinvasive is the very practical approach, and to educate our doctors in the periphery and to educate the society is also important. That these are the cardinal signs and
Absolutely,
symptoms of MI.
absolutely, yeah.
And what I advise my patients, if possible, the doctors also, if possible, get an ECG. Even in many places, many towns also, the ECG machine is not available. If you can get a ECG, do a photograph and send me by WhatsApp, then I advise do thrombolytic at home in the ambulance and transfer the patient to a hospital. That is the best option. We have to educate not only the society, but also the doctors also.
Doctors, right.
That way we can save the patients.
Yeah, very good comments, Dr. Sharma, from a very experienced professor like you. So, very good discussion. There is a, just if you permit, one short question by Dr. Ram. In the second wave of COVID, how much involvement of the heart and damage long term? So, Dr. Chinmay, would you like to answer this question?
See, in Wuhan, when the initially the data came out regarding ACS in COVID, so one thing came out, though the data are small, around 130 odd patients, that those patients with troponin had worse outcome. So same holds to nowadays are in this second wave. Initially, in my hospital, probably we have treated around 500 odd patients, maybe more, but hardly anyone had developed a frank MI, a STEMI, during hospitalization, though few had a higher troponin level. But this time, till date, we had around 5 MI in hospital MI while getting treatment for COVID. So this time, the possibility of having a STEMI is how I found it significantly higher. I do not know the reason behind it, but maybe that myocarditis or thrombotic milieu that is available during, that is prevalent during this COVID infection is responsible for this. However, all of these patients, I did only thrombolysis because of the logistic problem that I face, and all of them are doing okay. Some of them, 4 of them are discharged. So my opinion is that
Very good results. Yeah.
yes, sir. So that is
Yeah,
my
continue,
opinion.
please.
Getting more STEMI, and maybe this is related to, and all of them, all hospitalized patients this time are having a very high D-dimer levels. Most of them are very sick, and so all this pathology inside probably are leading to a higher possibilities of myocardial injury. So that is my observation.
Thank you
Arindam.
very much, Chinmay, for your nice remarks and your observation. I also agree with you regarding some of the comments, but many MIs we are getting, which are because of COVID. See, our experience is that, and in many of these cases, this is non-occlusive in nature. Suppose 30% blockade, and the patient had complete occlusion and a massive anterior MI, and then the patient was thrombolized somewhere. When we inject the artery, we find the artery is wide open with a 30-40% lesion in the proximal LAD. So that's better in one sense, that we could have avoided an unnecessary angioplasty, primary angioplasty. That is the only virtue of the pharmacoinvasive approach, and by which both are balanced together. That is one of the ways how it is balanced. And but the long-term result, as Dr. Ram has rightly pointed out. Thank you, Dr. Ram, for your nice question. Just I want to give you some data. In Germany, there was one study where they have done CMR in all the patients, and in 78% of the patients, they showed reduction in ejection fraction and myocarditis. But what to do in this situation, we don't know the answer. Day before yesterday at 2:30 in the night, I was chatting with one of my friends from US, who is also the co-chair of international of the Sky Academy. Sky, many of us are members of Sky, and he was telling that I asked him to get he had also COVID after 2 jabs of, this Pfizer vaccine. So he told me, what should we get? In 100% cases, we are getting myocarditis. similar experience with 1300 patients from Europe. They have got in 80% of the patients, they have got myocarditis post-COVID. In our country, we are not going for MRI because in echo, some of the cases are missed. So they suggest that as a routine in their country, it's possible because of finances. We don't advise for MRI, nuclear magnetic resonance imaging of the heart. So we go for echo, but the echo doesn't show always reduction in ejection fraction. That's our experience. But if we go for MRI, it shows slight reduction or sometimes optimal reduction of the ejection fraction and changes consistent with myocarditis. Anyhow, so these are some of the long-term specialties. Post-COVID cardiology, like post-COVID pulmonology, is coming into the fray. And without losing any time, thank you very much again, Chinmoy, for your nice deliberation. Thanks for to the other faculties. And Arindam is waiting for long. So Arindam, we know that he is a very dynamic interventional cardiologist, doing very well as a young cardiologist, one of the youngsters in our Eastern India, very dynamic, doing all sorts of imaging. I know him personally, and we have got very good relation too. And without wasting any time, I would invite Arindam to show your cases and STEMI management in cath lab COVID time. Really, we want to see how you have managed these STEMI patients in your center, Arindam. So please go on.
Thank you, sir. Thank you very much. It is always your guidance which help us to sail in the light. Dr. Kulkarni, please stop sharing. I can share from my end.
Okay, no problem. No
So one or two comments, fantastic discussion which was going on. One or two comments from my end. Compared to first wave, what I can say personally, this is my personal opinion, probably the number of myocarditis patients, we are seeing lesser number. This wave, second wave, compared to the first wave. Though the number of MI in COVID patients, that is still very, very high. And another very important aspect which I should discuss, this is not a common forum, this is not a forum for laymen or common people, but yes, I have come across quite a good number. In fact, few of my colleagues as well as friends has also come across few of the incidences of getting MI after getting the jab from AstraZeneca, the Covishield vaccine. In fact, if we go by the literature, we'll see that from UK, there is clear-cut indication probably this vaccine to some extent increases the thrombotic milieu inside our body, and there has been, I think, more than 150 case reports of acute either myocardial infarction or cerebrovascular accident after taking Covishield vaccine. So that we should keep in mind. And another very important, I am also a very strong proponent of pharmacoinvasive strategy, but one of the reasons why many people think that pharmacoinvasive probably will sell in our country because of the delay in presentation. Now, having said that, the delay in presentation, if we look at the efficacy of pharmacoinvasive molecule, whatever thrombolytic agent, the efficacy in the early hours is actually very high. So if you can thrombolyze within 3 hours, probably the efficacy will match that of the primary PCI. But if you delay it, then the efficacy gradually comes down. In fact, there is hardly any indication of doing thrombolysis after 12 hours of chest pain onset. And in this sort of situation, probably PCI is the only solution if you still think that the ongoing ischemia or other things which are going on. So that is also very important because nowadays the delay probably has gone up further. So we'll definitely strongly advocate pharmacoinvasive in this situation. But if somehow we cannot manage to thrombolyze the patient within initial 12 hours, we have to go for PCI in some of the cases. And that is very, very true because the delay has gone up further due to non-availability of the COVID testing, many a type rapid testing, which is very, very essential. I personally feel that rapid testing, particularly this one test known as CBNAT, is very, very early. We can get the result within 1 hour. That is extremely important, should be made available whichever center is planning for primary PCI or maintaining the primary PCI program in this COVID situation. Otherwise, it becomes very, very difficult. But the problem is that this CBNAT or any other rapid testing facility is not available widespread. So I think we are already late. So I'll try to finish as early as possible. STEMI management in cath lab in this COVID time. Now, I already mentioned there are some challenges in managing MI patient during COVID. First and foremost important thing is the patient delay. Already our country, if you look at CREATE registry or other registry, our patient, they actually delayed they do not need COVID-19 pandemic to delay their presentation to hospital with heart attack. Now this COVID-19, many patients, they are actually delaying it further. Many a time I have come across few incidences where the MI patient, because they are very afraid to reach a hospital. Most of the hospital are actually catering COVID patients as well. So they somehow had fatalities in their home. So that is the situation. So delay probably has gone up. At the same time, there are many patients, COVID-19 test is not widely available, and further, it is complicated by some abnormal features of the ECG. Many a time there are atypical ECGs due to COVID-19. There are abnormal values of troponin, which is further complicating the situation. Now, new challenges in this situation, STEMI care, as we all know, it is very, very urgency is inherent to it. And it has particular challenges. Now, COVID-19 has placed an enormous strain on the healthcare system with specific implications of the disease on practice in the catheterization laboratory, and cath lab in general are not designed to isolate infection, with most having either normal or positive ventilation system. And cath lab, they need to be carefully weigh the balance between staff exposure and patient benefit. We came across many of our staffs, many of the doctors, they got infected. There had been casualties. Only this week, one of the very renowned cardiologists from Patna, Dr. Prabhat Kumar, he used to work in Patna Medical Hospital. He expired at a very young age. So exposure to the staff is also extremely important. We should give proper respect to it. Now, if we look at the guidelines, the Western guideline, the American guideline, and ESC guideline, and the Indian consensus statement, and the consensus statement from the China, we'll find very important difference. Most of the Western guideline, even in the pandemic situation, they do advocate to go for primary PCI, whereas the Indian consensus statement, I'll briefly show that, as well as some of the consensus statement from China and Asian country, they feel that pharmacoinvasive strategy should be the preferred option in this situation. Why it is so? Because as we all know, due to the predominant practice of primary angioplasty, most of the European centers as well as US centers, they are very much accustomed to the primary PCI. In fact, it can be very important issue regarding the availability of thrombolytic agents. Such is the practice that majority of the hospital, they are doing primary PCI. They have forgotten how to use pharmacoinvasive strategy, the thrombolytic agent, and thrombolytic agent many a time is not available all the time. So still, this is probably the reason why they are actually sticking to the primary PCI protocol. Now, this one is very balanced sort of consensus statement from Dr. Matthew et al. The repercussion of STEMI in COVID-19 era, business as usual. It was published last year in JAC, and this consensus statement, very easily understandable flowchart. So first, they asked to assess the risk. So infarct-related artery location, whether it is a left main or proximal LED location sort of thing, hypotension, clinical classification, whether patient is having cardiogenic shock, life-threatening arrhythmia, and delayed presentation. As I already mentioned, more than 12 hours of presentation. Here, the thrombolytic therapy is actually not having enough evidence. So if you are having this kind of situation, probably you need to go for a PCI if the situation warrants so. Now, consideration for PCI, we need to weigh the risk and benefit to the patient and balance against the potential exposure of risk of going to the cath lab. I already mentioned that. Now, If those things are not there and the patient presented initially within 12 hours window, then actually we can think of fibrinolytic therapy. Now, importantly, we must understand there are some absolute contraindication. I'm not going to detail. So in this situation, whenever these contraindications are there, in these situations also, we cannot thrombolize the patient and we need to go for PCI. Say, for example, active bleeding or prior intracranial hemorrhage, ischemic cerebrovascular accident, which is very common within last 3 months. So these are the situations where you cannot thrombolize the patient. We need to go for PCI. Now, they have further elaborated that if the patient actually is a candidate for primary PCI, we should not defer the patient or should not we should not restrict ourselves from giving the benefit of primary PCI if we are very sure regarding the symptom of the patient. If it is sort of non-COVID like symptom, or many a time patients are coming to a hospital with COVID reports. So if those things are there, we should definitely go for primary PCI. In all other situations, we can actually administer fibrinolytic agent. So similar kind of algorithm was advocated by a group of physicians. This is actually the consensus statement of SCI, ACC, and American College of Emergency Physicians. So management of acute myocardial infarction during COVID-19 pandemic, published last year in JACC. And as per this algorithm, any patients with ST elevated myocardial infarction, either he can be a positive COVID patient, as Dr. Chinmay mentioned. He got 5 patients in hospital developing myocardial infarction who were all admitted for COVID treatment. So this is a very common situation nowadays. We are also getting good number of patients who are already positive patients, COVID positive, or their symptoms are very much suggestive of COVID. Say, for example, having fever, anosmia, loose motion, shortness of breath, and you can get a very quick CT scan of the chest, which can give you further information whether the patient is actually suffering from COVID-19. So these are one group of patients who are either COVID positive or probable COVID positive patients. So this group of patients we need to deal in one way, and other patients who are actually not having this kind of situation, but the dictum is you need to consider everybody to be a potential source or potential risk for COVID-19. So in this second group of patients, we should also keep all the mechanism of not getting exposed. So important difference between these two group of patients. First group, if it is a COVID-19 positive or probable patient, then you need to have a dedicated COVID-19 cath lab. So apart from that, all other things are almost same, because dedicated cath lab you need to have. So any hospital which are having more than one cath lab, you can have this facility. So you can dedicate one of your cath lab as dedicated cath lab for COVID patient or suspected COVID patient. Exactly this is the situation in my hospital. I'm having in my hospital we do have 2 cath labs. So one of the cath lab is actually a dedicated COVID cath lab or dedicated suspected COVID cath lab, where we do all kind of COVID positive patients and probable patients. We do sterilize the lab each time after use, but that lab is a dedicated COVID lab. So that is very, very important. So if someone who is having a COVID-19 possibility, but he's somehow tested, say for example, we now have very rapid tests which are available, so negative tests. So those kind of tests are very rapid, but they are not very sensitive in picking up the diagnosis. In those situations, universal use of PPE for aerosolized as well as droplet precaution is advocated. So this is the consensus from American side. This is the ESC guidance for diagnosis and management of cardiovascular disease during COVID-19 pandemic. What they say, the maximum delay for STEMI diagnosis to reperfusion of 120 minutes should remain the goal for reperfusion therapy under the following consideration. But at the same time, additionally, they have clearly mentioned that primary PCI pathway may be delayed during the pandemic, and up to 60 minutes of delay, according to multiple experience, it should be acceptable. So if the target time cannot be met, and fibrinolysis is not a contraindicated, then fibrinolysis should become first therapy. So this ESC guideline, actually somehow it is in between ACC and our guidelines. So they say, yes, we should estimate the delay, how much delay is going to be taking place. Normally the delay is 120 minutes up to 60 minutes extra. So 180 minutes of delay after the patient has arrived to the hospital is acceptable. But if it is going beyond that and the patient is a candidate for fibrinolysis, they also advocate to use thrombolytic therapy. So that is very, very important. Now, why the delay? I'm not going to detail. So all the patients, we should estimate how much delay there can be in initiating a particular type of therapy. Now, this is another recommendation. This is a recommendation from Peking Union Medical College Hospital for the management of the same situation. Now, the Peking Union Medical College Hospital is a hospital which is situated in Beijing. So this is basically a Chinese protocol. So management of suspected STEMI patient with potential risk of COVID-19 infection, they clearly mention that all the situation, we can see that they advocate first we should go for thrombolysis or fibrinolysis. Now, if the patient has special circumstances, say for example, presented very early within 1 hour, possibility of COVID-19 is clinically small, or we can have other issues, say for example, on-site thrombolysis facility is not there, or it is a failed thrombolysis that Dr. Chinmay mentioned, rescue PCI case. So those are the situation we should take the patient for PCI. So this is a sort of Chinese protocol, a Chinese hospital algorithm. Now, Cardiological Society of India on acute myocardial infarction care during COVID-19, they had a consensus statement last year, and we are having Dr. Dhiman Kahali, who was also part of this consensus statement. We'll briefly go through it, what they recommend. So they recommend to screen every patient for history of international travels or contact. So this was last year's consensus statement. So I think there should have been some changes, because now India is the capital of COVID-19. So international travel history and those things are no longer very, very relevant. Now, respiratory status of the patient should be assessed and classified. Patients presenting with acute MI could be classified into 3 groups. First group, confirmed COVID patients, which is nowadays very, very common. So positive COVID-19 patient, at that time it was rare in community, but now as the community transmission is already going on, so we get good number of patients who are COVID positive at the same time having MI. So first group is the confirmed COVID. Second group, group B, is the suspected COVID. I already mentioned the suspected COVID. So in this group of patients, rapid testing would permit quick classification of the patient. And third group is the low clinical probability of being COVID-19, or group C. So no symptom, suggestive of influenza, no history of travel, contact with COVID-19 patient, and the COVID-19 test is negative. This is this is also a good number of patients who present to us. Now, what CSI recommend, they recommend to club both group A and group B together due to non-availability of rapid testing. Most of the hospitals we do not have rapid testing facility, and for confirmed patient we need to keep another group. So if there is no contraindication in this first 2 group, CSI last year, they advocated to use thrombolysis as the prudent option to avoid time delay and protection of cardiac catheterization laboratory personnel, especially if the patient is hemodynamically stable. Now, if the patient is hemodynamically unstable, primary PCI would have been ideal option, especially COVID-19 pneumonia respiratory status is assessed as mild to moderate. Similarly, thrombolysis should still be tried even if patient is unstable, with plan for rescue PCI due to prevailing logistic problems. So those are the recommendations from Cardiological Society of India. And primary PCI should not be performed if adequate PPE are not available. They had clearly mentioned. And in group C patient, where the probability of COVID is very low, utilize pre-COVID strategy as per previous guideline, but based on prevailing logistic, thrombolysis could still be considered to decrease the overall critical care and inpatient service burden. So what we can see, the STEMI management protocol to some extent was skewed towards advocacy of thrombolysis therapy, the Indian recommendation. Now, for stable end STEMI, so other group of acute coronary syndrome, unstable angina, and stable non-ST elevated myocardial infarction, coronary angiography has to be deferred until the COVID-19 test is available. And for the confirmed and suspected COVID-19 patient, thrombolysis should be given in isolation room area within designated ICU as per institutional protocol. These are additional recommendation in small town and villages at the spokes in a hub or spoke model of STEMI care, which is very nicely followed in Karnataka and Tamil Nadu. Thrombolysis should be preferred for reperfusion strategy, and institutional transfer should be discouraged. They have gone to that extent. Now, cath lab consideration during COVID-19 pandemic from ACC's Intervention Council and SKY, if we look further, they have clearly mentioned relatively stable STEMI patient infected with COVID-19, fibrinolysis can be a therapeutic option. When primary PCI is performed in STEMI patient with active COVID-19, personnel should wear a PPE and use a powered air purifying respirator or PAPR system is also reasonable, in particularly for vomiting patient or those who require CPR or intubation. So those are the recommendations from SKY. Now, China, another recommendation. So this is a protocol from Sichuan Provincial People's Hospital, a large medical center for which was massively affected by epidemic at that period of time. How to balance AMI and COVID-19? The protocol of this hospital, they also very, very clearly were skewed towards performing thrombolytic therapy. You can see most of the cases they have advised to perform thrombolysis, except in failed thrombolysis or shock patient, hemodynamically unstable patient, very delayed presentation, but at the same time ongoing ischemia. Those are the situations they had advocated for performing PCI. So these are the summary. I should probably skip those up those. So with that, I'd like to finish this last slide of my presentation. Present COVID-19 pandemic is a medical emergency of unprecedented scale. The risk-benefit ratio of primary PCI versus lytic therapy to both the patient as well as hospital personnel will have to be assessed. And in hospital, if the hospitals are overwhelmed with COVID-19 patients, the feasibility of timely primary PCI will be a challenge, and situation should be dealt in accordance with available resources. For confirmed or suspected COVID-19 patient with STEMI presenting within 12 hours with no contraindication, thrombolysis is the prudent option to avoid time delay and for protection of cardiac catheterization laboratory personnel, especially if the patient is hemodynamically stable. And primary PCI should not be performed if adequate PPEs are not available. All the guidelines and recommendation bodies are very, very uniform regarding this, and preferably perform in an isolated catheterization laboratory with minimum trained personnel to reduce the nosocomial spread. If the patient is hemodynamically unstable, primary PCI would be an ideal option, especially if the COVID-19 pneumonia respiratory status assessed mild to moderate. And for cath lab staff and patients, consider essential life-saving procedure with suspected or confirmed COVID-19. All staff must use maximum PPE and re-establish a safe environment when the case is over. With that, I'd like to conclude. Thank you very much.
So thank you, Dr. Pandey, for your excellent lecture. Not only you have given a very wonderful lecture, but also you have finished in time. And you not only touched our Indian guideline, you have also touched the European, the ACC, even many of the smaller guidelines by different universities of China, because it is no denying a fact that China told us so many things about a year back, and we got the essence of the disease, that it's mainly a vascular disease, rather a viral infection, and it's the cytokine storm which has been the major cause of death in this patient. So anyhow, both the orators were excellent, superb in their deliberation, and both of them have finished in their time, and they have touched all the valid points. Like Western countries, we cannot go for primary PCI in all the countries. Though in our hospital, we have 3 labs, we are going to have soon 4 labs. So the third lab is, for primary PCI patient, but if there is no primary PCI, we don't lose the revenue. We take patients in between because we sterilize the lab, we fumigate the lab for 2 hours after the doing a COVID positive patient. But no COVID positive patient who wants a primary PCI, because now it's not a choice of the doctors also, it's the choice of the patient and their families. Some patients are so educated nowadays, they come and tell, sir, in our hospital we will do primary though. Yes, we do primary, so that those patients, even COVID positive, we take the patient for primary PCI. And as Dr. Pandey and Chinmay touched the points, very correctly, that in all the centers, the report of SARS-CoV-2 is not done in time. It takes 24 to 72 hours according to the situation of the lab in different metros and districts. Like in our hospital, we have got the facility for doing this SARS-CoV-2 as an outpatient basis, and it takes not more than 1 hour. So we can get the result within 1 hour. And as Arindam has mentioned, that ESC has given an increment of 60 minutes. That is the ESC 2017 update shows from the Barcelona ESC, that it should be within 120 minutes and the delay should not be more than 120 minutes. And if the delay is more than 120 minutes, we should go for the thrombolysis, and then we should go for the primary pharmacoinvasive PCI. And we should remember one thing, that all the data which we have seen in both the presenters, they did the pharmacoinvasive, the invasive portion they did at 3 hours, not at 24 hours. So all the data shows that they were done very early, and the thrombolytic agent was also tenecteplase. So we would like, if we follow the Western guidelines, we would also follow their teachings, that we would like to give tenecteplase in this group of patients, because with streptokinase we haven't got a lot of data, though we have got some data from India and from some Latin American countries, because streptokinase is not used other than these countries in UK or US. If somebody wants to thrombolyze, they always go for tenecteplase or retiplase. So the timing is very important in pharmacoinvasive strategy, and we should not delay the procedure. Especially if it is a failed thrombolysis, we should not hesitate to take the patient immediately after the failed thrombolysis is recognized, as evidenced by continuation of the chest pain and non-resolution of the ST segment elevation. So both the orators were excellent, superb, and I congratulate both the speakers, Chinmay and Arindam, both of you. Really, you have touched everything whichever is required for PCI in STEMI situation. You talked a little about NSTEMI also, and you talked as a whole. And you also emphasized that we should not forget about the cath lab staff. I think as able doctors, we should look at our associates. We should not forget about that. Even a single person inside the cath lab, even a GDA, because sometimes the patients want to urinate and all these things. So GDA also come. He should also not come. He's not a regular visitor. He should also not come without PP. So we should be ready with the PP. And as Arindam and Chinmay repeatedly mentioned, that we should have a negative pressure in the cath lab, if possible. That's very important. We should not have a positive pressure or neutral. That's very important, because COVID is affecting each and every household. And this variant B1617 is affecting 9 out of the 10 family members or friends or neighbors. It's something different from the first wave. It's dangerous, and its mortality is very high. This morning I got, the patient had problems. I had done angioplasty 14 years back. His son is a medical representative. He gave me the bad news that, sir, we have lost our father. He told me that he had COVID, took me advices, and he told he didn't have any cardiac problem till the last moment. That is their gratefulness. And they told he died of acute renal insufficiency, AKI. The creatinine became 5, the urea was 200. So I think they have touched all the good points, but we have got two very good professors with us, Kajol, who is a very good friend of mine, and also Dr. P.C. Sharma, who too is a good friend of mine. So I would request first Kajol and then Dr. P.C. Sharma about their comments and any comments, critical comments about the how we should work in the cath lab in this PC in COVID scenario. So Kajal, please, Professor Ganguly. Dr. Ganguly, you are not seen.
Ah,
Yeah, please come on. Kajal, please, you are muted, Kajal, you are muted. Yeah, you are muted, Kajal. You please unmute yourself. Okay, by that time, Dr. PC Sharma, if you are ready, please come with your vital comments.
now Dhiman, am I audible?
Dr.
Am I
Yeah,
audible?
yeah, very loudly audible now. You
Yes,
have
yes, yes.
compensated your muteness with a very loud sound now. Really,
Yes,
it was
yes. Now
nicely audible.
regarding
Yeah,
the myocarditis part. Now a study is going on
yeah.
in our Apollo hospital where the patients who are recovered from COVID are tested for the myocardial involvement, and they are doing quantitative tropi and also the GLS, that is the strain rate imaging. You will be surprised to know that this patient who had mild symptoms, their GLS level is less than 14, moderate, their GLS level is 14 to 19, and who had severe symptoms, they had GLS level more than 19. Although the number of patients is almost 200, that is coming up. They are doing a good study on it. So GLS is a criteria to study the myocardial function, where in all these patients, ejection fraction was normal. So tropi quantitative value and GLS assessment gives you a very good idea of cardiac involvement in COVID patients. Number
And
two.
especially in the presence of a person like Dr. P.K. Tiwari. He is very good in echo, yeah.
Yes, yes. This study is they are doing with Anuruddha Dey and others, and there is a very nice study, and we are also sending the cases. So there is one part, and regarding this pharmacoinvasive therapy and use of cath lab, one should be very cautious. As you have rightly pointed out, we should see also our supporting staff. So in patients doing positive cases doing cath lab, we must be very careful. And this positive pressure ventilation and others has to be negative pressure has to be maintained, which is not done in our cath labs. It's important. And very selected patients are to be taken to the cath lab for this the primary PCI and others. So both Chinmoy and this and our Arindam, they have done very good works. I congratulate them and thank them for their beautiful deliberation.
So
And
Dr.
also
Sharma,
you
please.
for your fine anchoring.
Thank you, Kajal. You are my great friend. Thank you, Kajal. The Kajal, one thing, if we are interested, suppose Arindam, I want to send patient to increase the numbers because if we want to, I don't think any such study is going on because in abroad they are doing with the cardiac MRI, as I told you, but you are doing with straining, which is relatively cheaper and much cheaper than the cardiac MRI. Would you accept patient from us?
Yes,
if we want to join the study? Because
yes,
then
yes.
you have a bigger numbers, a much better statistical power.
Yes, yes. There we have got patients. We have got almost theory and
So,
others.
okay, I and Arindam will be in touch
Sure,
with
sure.
you and we can
That
contribute to
is
increase your numbers. And I
sure.
don't know whether for Chinmoy it will be possible, but we can definitely contribute to increase the numbers. Okay, Dr. Sharma, thank you, Kajal, for your excellent remarks.
I fully agree with their presentation that they have very nicely presented. Congratulations to both of them. In COVID patients, I have one question, rather doubt, that if patient is COVID positive, now if we think of taking him to the cath lab, now we need to assess his lung functions also, how much of pulmonary involvement. Suppose we are going to do something with his coronaries, but at the same time his pulmonary involvement is more. What will be the total outcome of the patient? And his myocardium is irritable, there is myocarditis. And whether it is a big vessel disease or small vessel disease causing troponin elevation, ST segment deviation, etc. That is also important before going for any intervention. Not to speak of that safety of the hospital, it is true. But ultimate outcome will depend upon the patient's total evaluation of the patient.
Absolutely, Dr. Sharma. I agree with you. Very good comments that if the patient is very bad, But we can assess the patient clinically also. Not necessarily we have to go for a HRCT. It is difficult to go for HRCT in the same sitting in many, many hospitals. It's not possible, either
Mhm.
it is busy or it is in another building. Like in our hospital, we have the CT, but in the next building. So it takes time, takes involvement. But if we clinically examine, if the patient has very high fever, if the patient is excessively tachypneic, respiratory rate 36, 40, like that, and if the patient is very sick, hypotensive, then of course very much tachycardic, this sort of patients we have to take with caution. We have to talk with the patient relatives that the outcome is not very bright. But again, if this patient has a massive damage to the heart, that situation will be further worsened. So if required, we can put the patient to the ventilator and we can do the job. We can finish with 40 ml, 50 ml of dye, doing the angiogram and opening up the IRA. And not necessarily always we have to put a stent. We can go for a balloon dilatation, open up the artery and come back. And later on, if you think, though the deferred trial is outdated now and we don't go for deferred stenting, but what I want to mean that giving a stent and suppose the patient has bleeding or something, the chances of thrombosis are more because it's a vascular disease. There is endothelial damage. There is damage in the whole cascade of the clotting system. So it's not very wise to always in these very, very bad patients to put a stent, rather come out with doing a balloon stent and balloon angioplasty. And if you are happy with it, otherwise put a stent. A stent like Giants or a stent like Resolute Onyx, which we can give a single antiplatelet agent for 1 to 3 months. And if required, if the patient has high bleeding risk, we can put such good stents and we can come out. And I don't think putting some little dye will alter the patient, but it will help by preserving the good myocardial function because at least from one front, the patient will be saved that he has no heart problem. Because if you can do a good job, many a times we find a good ejection fraction after the good procedure, especially if done in the early hours. And in that case, we are going to achieve. Because thrombolizing such a patient is always dangerous. As he mentioned, if the patient is, as Arindam mentioned, if the patient is in cardiogenic shock, because many such patients have severe hypotension, they need ventilatory support, immediately they land. So such patients, I think better than thrombolysis, primary is a better option. And there is no doubt, whatever we write, whatever the different, you see with STEP AMI, only 200 patients were taken. It's not a big deal, we can't comment from that the primary, personally, I think they are nodding in affirmity, I see Arindam, Chinmay, they're all supporting me that we all believe primary PCI is much better than thrombolysis. There is no intracranial hemorrhage, there is no major hemorrhage, there is no hematoma. After you perform a beautiful angioplasty, you find a big hematoma, retroperitoneal hematoma. This do occur. We are sure that if we do the, especially they are doing a lot of radial intervention, the youngsters, you do through the radial and you do the job, come back with 40, 50 cc of dye, it's not a big deal. Don't touch the non-culprit arteries. And you present him a 55, 60% ventricle. So at least from one front, we are sure that we have given a good ventricle to the patient. And okay, then let us fight for the COVID. Now the COVID treatment is also very good. The pulmonologists, the infectious disease experts, they work together. And previously, initially, when we thought these patients cannot be saved, many such patients are being saved with 50 liters of oxygen, with 80% FiO2, with the flow machines, not even putting the patient on invasive ventilation and giving if there is cytokine storm as the steroids tocilizumab and query remdesivir now because who has told we don't need it, but who hasn't got any authority, I think, where we cannot take every of their proponents as gospels. We have found with time it changes, and so we haven't got, I at least haven't got much faith on, because we have found that remdesivir reduces the duration of the hospital stay, though it doesn't reduce the mortality. So we can deal with the patient in a better way. And we can assess the patient. Okay, if we think that the patient is going to die out of COVID, don't do the primary. Simple. But those are very few patients, majority of the patients we can assess clinically. Because whatever comes, MRI, CT, HRCT, but first and foremost is our clinical sense. If we find, okay, the patient is moderately ill, and it's a moderate to severe COVID, and our clinical assessment becomes true in majority of the patient. Take the patient on the table, do the job with all PP, doctors, paramedical staff, everybody, the technicians, the sisters, brothers, everybody with PP, do the job, send the patient to the suspected CCU. Like we have kept a suspected CCU. As the patient enters, we think that all has COVID. After he becomes COVID negative, we send to the clean CCU. That's our system. So you do the job, send, make the patient safe. If you find that the patient is too sick, I think, but I thank you very much, Dr. Sharma. You have raised a very, very good question. Arindam, what is your opinion?
Sir, my opinion is I fully agree with you. If the patient is having moderate pneumonia, I'm not talking about severe pneumonia. If the patient is having moderate, mild to
Yeah,
moderate pneumonia, and who are the patients who are being taken to cath lab? These are very sick, clear-cut indication for doing intervention. So ST-elevated myocardial infarction is
yeah,
a clear-cut indication for doing intervention, and the benefit actually is passed on. There is mortality benefit. There are improvement of quality of life
absolutely.
later on, and I'm following this protocol. I'm taking all the COVID patients who are presenting to me within period window or ongoing ischemia. Last wave, this wave, I'm doing all COVID patients who are presenting with STEMI, the primary only. And my experience, they are doing fantastic. They're doing fantastic because I fully agree with Dr. Dhiman Kahali that if the patient is having problem of both lungs and heart, if you can improve the cardiac function, that is going to be a huge improvement, because it
Absolutely.
takes time to improve the lung function, not that easy as well. The medicines are not very straightforward, whereas the treatment for cardiac illness is very straightforward, and we know the outcome. We're doing it for a very long time, and that improves the outcome. I have seen from my whatever small experience, but I am very in favor of doing primary PCI if the patient presents to me within window.
Absolutely. So, Chinmay, any further addition if you have to tell something over and above this one, because we are going behind the time. We are already 9:05. So, short comments, please, Chinmay.
I agree with your comments. But my hospital, I have single cath lab, so it is not always possible for me to follow this.
Yeah, that's a problem. That's also a practical problem. Kajal, any further comments, Kajal?
I think Dr. Ganguly has left.
Left. Okay. So, okay, Kajal has left. So, I think we had any question in the chat box. In the second wave of COVID has brought all the different specialty to come out of cellos and need to work as a team. That's very true, Dr. Ram. I think you have been seeing, though we belong to the same specialty, but we have been working together, and our opinion is also same. And we do need the support of doctors like you, Dr. Ram, for your beautiful comments and your active participation. Now, any more comments from we would invite for more chat box typing, yeah, there is immediately another, but from the same person. Mucormycosis impact on diabetic STEMI patients, what precautions need to be taken for primary PCI, even the patient has recovered earlier from this. So, Arindam, can you answer?
Four cases
Very
in
nice question, Dr. Ram. Thank you, Dr. Ram. Yeah,
four cases
he's
of
very active. We find,
yeah
yeah,
four cases
yes,
of
Arindam.
mucormycosis is diagnosed in West Bengal still now, and out of these four cases, three cases is from my hospital. So it is not very common. First of all, it has become a pandemic like situation in Maharashtra, Rajasthan, and Gujarat. But most majority of the people, they're saying this is because of widespread use of steroid. Steroid is important because steroid is the only molecule which has consistently shown benefit. It has improved mortality, it has reduced the hospital stay, it has improved the quality of life. The same time, it comes with a price tag. But I also would like to suggest two different mechanisms as well. Probably COVID-19 virus itself is playing with the immunity of the patients. So it is not only the steroid, probably COVID-19 is also playing some form of role in so much increased prevalence. In our state, it is not that prevalent, but the whatever we can hear from our colleagues of Gujarat, Maharashtra, and Rajasthan, it has become very, very rampant. And another very important point which I'd like to mention regarding this, of late, Government of India has given permission to use industrial oxygen for COVID-19 treatment, or for the matter of say any medical use. They have given this permission. Now I don't know whether this industrial oxygen has something to do with this so much increased prevalence of mucormycosis, because as we all know, the medical oxygen, it comes in another way, the sterilization and all, but the industrial oxygen, probably the sterilization part is not properly taken care of, and it can be contaminated with soils and other contaminant which might be a source of mucormycosis. So these are my my suggestion regarding this situation.
Yeah. But Arindam, if you see the literature on oxygen, the industrial oxygen is 99% oxygen, and the medical oxygen is 93 plus minus 2.5% oxygen. So there is not much of a difference between the, strength is concerned. And so it has been postulated, because Bhabutur is also in the guideline committee of, he's the principal chairman, or he's chairing the task force on this India government task force. So what we gather that there is not much of a difference between the industrial oxygen and the medical oxygen, and both are manufactured in a good way. So, and they are also taken in good way. But okay, as you were telling, because taking these things in railways, in wagons, and how far they are kept clean, that is of course to be seen. But the main two reasons which are being incriminated to answer Dr. Ram's question has also been told in a very nice way by Arindam. That number one is overuse of steroids, which is necessary to save the patient. And the duration is also not sometimes maintained, because out of fear or apprehension, when the cytokine storm is over, we continue it to keep our patient good. That is from a good idea on the part of the physician to keep their patient, but little overzealous treatment with steroids. And second thing, which he has mentioned, is also equally important, that this diminishes the, you know, immunity towards any infection. So these are opportunistic infections, and this fungal infection, mucormycosis, it may be black, it may be white, whatever, and they're telling white one is worse than the black one. And so this mucormycosis, as you have rightly designated, Dr. Ram, I think is of concern. But till now, total, we have faced only 500 cases in the country. So it's not that big a problem. And as he has mentioned, I also like to point out another fact, that another modality of treatment is surfacing, which is the hyperglycemia, which is induced by these steroids. And so we need the expert and very reasonable guidance by our diabetologist to control the hyperglycemia during steroid use, and then to reduce the dosage of insulin as and when required. And even sometimes we can omit the insulin totally and give them on simple OHA. So these are the guidelines. For not any guidelines is there, but this is the guideline given by the government of India, considering so many cases of mucormycosis. But it is not an epidemic or pandemic like COVID-19 till now, fortunately. In only 2-3 states, as Arindam rightly mentioned, it has surfaced, and he has seen the 3 cases here. We haven't got any case in our center till now. So I don't think it is very difficult to treat, and the antifungal agents, being
Amphotericin
available
B,
in our
amphotericin
country
B,
in
yeah,
abundance. Yeah, amphotericin. And
B.
another antifungal also you can use, because there are so many antifungal agents now, but those are all from the family of amphotericin B. By changing the side chains, they are different nomenclatures. So I think our infectious disease experts will guide us properly to deal with this also. But of course, the mortality is very high. and we have come out of the COVID successfully with a huge prize by letting our patient go to have a holy dip in the Kumbh Mela, electioneering this and that. We don't want to gossip about the political issues, but one thing we feel as doctors and cardiologists, that we are against the wall because of no fault of us. Do you agree or not, Arindam, Chinmay,
Yeah,
Dr. Sharma?
fully agree.
So
Fully agree.
all of us fully agree. And I think it was a beautiful discussion. Thank you, Dr. Ram. Thank other participants. I also thank very much the two speakers, Dr. Anindam Pandey and Dr. Chinmay Mojumdar. Their classmates I heard. And Dr. P.C. Sharma, Professor Sharma is a good friend for me, long. And Dr. Kajal Ganguly, who was there very active. Also, Dr. Ketan, you had been there before the meeting started. Thank you very much. And also Nana Sahib, Moni Singh. Sahib has been active, and from the eastern part, Protut Poni and others who are very active from the MQ New Care division. And we are very happy with your molecule of this tenecteplase. So you are helping us a lot in this difficult situation. And also I thank from my heart because of organizing such beautiful seminars every month. And I'm really grateful to you for educating people, because I find rather than the non-COVID time, we are finding we are learning more and more. Just now I learned, Arindam, I was before joining here I was also anchor with, I showed a case also live that is organized by Sun Pharma every Friday, third Friday. Shamin is showing from cases from Mount Sinai in one where I was the anchor. I also showed a case from our end, and we discussed between us. So he showed that he used this impeller in a patient where the ejection fraction was good, LVDP was little high, 28, and the usage was because of the fact RCA was totally occluded and LMCA had a very tight lesion, calcified 70-80% distal left main, and the use was some, and this has been approved by the FDA. That is what I learned, that so we can use with good ejection fraction, not necessarily with a high LVDP, there is no mention, but with some complex PCI with some binding cause, because
short-term
our
use.
yeah, RCA 100% occlusion with left main lesion is a contraindication for performing PCI on left main. That's in the textbook, about the contraindications of left main PCI. So each and everything, I just gave an instance that every moment we are learning from these webinars, and I am really very grateful, and I have great gratitude for organizing such beautiful seminars. And I am also seeing the dynamicity of our young cardiologists, and I'm really fascinated to see the beautiful work they have been doing during this COVID era, the insight they have got like a very veteran cardiologist and talking like a very prudent cardiologist with 40 years experience. Really, thank you both the youngsters. Thank you, Professor Sharma, who is little aged like me. But we have been also been participating for a long time. It's almost 2 hours since we are together. And thank you very much, everybody, all the faculties, all the delegates, all the participants, and also Ketan, Nana Sahib, Monish, Pratut Muni, everybody of MQ for organizing such a beautiful. So we would conclude the session after a few words from Ketan, I think.
Yeah. So thank you.
Thank you very much.
I wish to thank all the faculties, Dr. Dimam Kali, your valuable advice to all the budding cardiologists and all the audience. Thank you very much for that. Dr. Arindam Pandey, sir,
They
thanks.
are not budding. They have already full blown.
Yes,
Ketan,
yes.
I object. They are not budding. They are full blown now.
Full blown. Yeah. Full blown.
Yeah.
Yeah. So thank you, both of you, Dr. Arindam and Dr. Chinmay Muzumdar, sir. And Dr. P.C. Sharma, sir, thank you very much for your insights, and also to Dr. Kajal Ganguly, sir. So thank you very much. And I wish from our side, sir, stay safe. And thank you for all the help to the patients during this COVID time. COVID has 360 degrees changed our life. So thank you, all of you, for saving the lives of many patients. Thank you. Thank you.
Thank you, and good night to everybody. Thank you.
Good night.
Everyone, please take care. Good night.